Thank you very much, and good afternoon. Thank you for joining us today on the first day of the Lunar New Year, and hopefully that gives us some optimism for our future as well. I want to start off today by talking a little bit about our treatment update. So as you know, 2 weeks ago, Health Canada approved another tool that we have in our toolbox to help us manage this pandemic, and that is a medication called Paxlovid, which is a combination of two drugs, nirmatrelvir and ritonavir. And it was given, one of the things that we needed to do was get a better understanding of who would best be suited for this drug here in British Columbia and how we could use it with the limited amounts that we received to begin with. So our BC COVID-19 Therapeutics Committee, I'm very grateful for all the work they've been doing over this past 2 years. They set about trying to come up with our rational approach to how we're going to use this. This is another positive step forward in our COVID-19 journey, and the treatment is specifically for people who are at highest risk of having more severe illness and hospitalization, and it needs to be started within 5 days of symptom onset. So for that, of course, we need to make sure that we have testing available for people. So we've been aligning both the limited supply we have, about 4,000 treatment courses of these medications, with our testing strategy as well. And I'm very grateful for the infectious disease teams in each of our health authorities. We have developed a hub and spoke model so that this medication can be available through our infectious disease teams, and they are able to identify people who are, for this very initial supply of medication, who are most at risk and who we can get it to in that critical period of time. And you will recall 2 Fridays ago we presented a heat map, and we use that information to identify those people in British Columbia who are more at risk of requiring hospital care. And we've identified that it is essentially the people who are in our critically extremely vulnerable groups 1 and 2. So those are those people who have immune compromising conditions because of medications that they're on, because of having had a transplant or undergoing certain cancer therapies. So those are the people who will now have access to this drug. The things that we are learning, though, from this medication is that these are conditional recommendations, and this is a very challenging medication combination. Every medication comes with risks and benefits, but this new antiviral combination has some very important what we call contraindications, so it can't be used in some cases, and it also has some very important drug-drug interactions. So unfortunately, many of the people who would potentially benefit from this medication take some of those medications that interact with it. And it makes it very different from some of the other antivirals we have, like Tamiflu, for example. So people with we have to be mindful of people's kidney function, the immune suppressant medications they're on, anticoagulants. These are some of the very serious interactions. So our teams who are most familiar with using these antiviral drugs, particularly ritonavir, which is a protease inhibitor, it's part of a combination of drugs that we also use for treating people with HIV, they will be starting to offer Paxlovid and to people in the highest risk groups, and we'll be reaching out to them through a proactive process of monitoring our lab data. So it is important, if you are one of those high-risk people, to continue to access lab testing as you are part of the testing guidelines. And along with this, we will be posting later today some of the detailed information for people so they can look at whether they qualify for this medication, but also the updated testing guidelines to make sure that people who do qualify for it are able to get a test quickly and rapidly. And I just want to say my thanks again to our infectious disease teams and the health authorities, but also to the teams at the BC Renal, BC Cancer, and BC Transplant, because we know that you'll be reaching out and having these discussions with your high-risk patients. This, of course, is another tool, but as I said, there's still much that we need to learn about how to use it and who it can be used in and what the side effects and the risks and benefits are. And most importantly, it is used once somebody has been infected and is at risk of having severe enough illness to need hospitalization. And we know that the most important thing we can do is prevent infection in the first place, and particularly in people who are at high risk, the importance of vaccination. And that is one of the things that reminds us that we need to pay attention to increasing immunity, particularly if you are somebody vulnerable. And so in that light, in mid-January, we shared that we are updating how we'll report on hospitalizations to provide a more fulsome account of everybody who is in hospital with COVID-19 positive test on any given day. And we are at the highest levels of people that we've had in hospital in this whole pandemic. Hospitalizations are what we call a lagging indicator. It takes time, and we have had very high levels of transmission in the community for some time now, and we have seen this translate into hospitalizations most recently. And this is where we are experiencing at the moment. So I'm going to walk us through the information that we've done to look at who is in hospital right now. When we presented the updating reporting, we talked about the census data. So it includes everybody who's in hospital because of COVID-19, whether the COVID-19 is causing respiratory illness or exacerbation of other underlying conditions like heart disease or lung disease. So people who are admitted because of COVID-19. And we're also looking at people who are admitted to hospital with COVID-19. So they're admitted for another reason, and they either acquire it in hospital or somebody is screened or tested with either very mild illness or because they've been screened on admission. And those are the people who are admitted not because of COVID-19, but with a positive lab test. And we need to understand those two populations to help us understand how we're going to get through this phase. So what we have here is a familiar slide of the pandemic to date, what we've seen in terms of hospitalizations, and particularly what we're looking at in the last month. So we've had 63 new people. We've had 706 new people admitted to hospital this week as of the 30th of January, the week ending the 30th of January, out of 11,539 new cases. As we can see from the blue line, it does look like we are at our peak of hospitalizations, and this is where we would expect to be, given the modeling that we've been using to help us understand the trajectory. The other thing that we look at, of course, is by age. Who is getting admitted in higher rates than others? And what we are seeing, that it's coming down along all age groups. That bump up that we saw in the younger 0 to 19-year age group has leveled off and is also starting to come down. So when we look at who is in hospital, there's a number of important things to look at. One of them is what is the variant of concern that's causing hospitalization right now. So as we can see, it takes a bit of time for us to do the whole genome sequencing once somebody's been admitted to hospital to understand exactly what strain they have. But it's very clear that as we've progressed into January, Omicron has been more and more of the cause related to hospitalization, the strain related to hospitalization overtaking Delta. Although we still have people in hospital with Delta, people being admitted because of infections with Delta as well. If we look at the characterizations of people who are hospitalized, using this breakdown between Delta and Omicron, we can compare and see what the differences are in what we're seeing. And one of the important things we're seeing is that Delta, for the most part, was very strongly, hospitalization from Delta was much more common in people who were not vaccinated. Now with Omicron, the unvaccinated are a smaller proportion And partly that's because some of the people, a good proportion of people in hospital, and I'll have that data to show you, are people who are admitted for other reasons and have a positive COVID test. So it's not COVID that's driving them into hospital. The median age is about the same, and I think this is something important. Early on, when we were trying to understand if Omicron causes more severe illness than Delta or not, we were seeing it more in younger people. So it was hard to tell if it was because people were younger and vaccinated or because it was milder in and of itself. We are now seeing that we're in that older age group that is requiring hospitalization. So that gives us some hint. We're also seeing that the proportion of people over age 80 is now higher, which gives us a sense as well about two things. One is people over age 80 are still at highest risk of having severe illness. This is something we've seen all along, whether they're vaccinated or not. We also know that people over age 80 are much more likely to have other underlying illnesses, which may be a reason why they are admitted to hospital and could be screened for COVID. The length of stay that we're seeing, which is really important in how we manage our hospital care right now, and the burden of people who are in hospital right now, particularly when we know that healthcare workers are off with illness themselves. So what we are seeing, thankfully, is that we continue to see a shorter length of stay, approximately half the time that people are in hospital with the Omicron compared to Delta. And so that does mean that people who have been admitted in December and January are still in hospital, and many more of those people would be from Delta that are in for a longer period of time. We also thankfully see a much smaller proportion of people requiring critical care. So that is either supplemental oxygen in the ICU or ventilation and other important interventions to keep the circulation and blood system going. And we are also thankfully seeing a much lower rate of death in people who are hospitalized, about half the rate now. So what does this mean overall? So if we look at our hospital admissions, and this is done from detailed chart reviews of 550 people across the province. So I had presented 2 weeks ago some very similar data that came out of Vancouver Coastal. We've now done the chart review of the 550 people who were admitted to hospital. So they're on admission. Some of those people are still in hospital today. Some of them would have been discharged by now. And this is across the province, and broken it down by people who were admitted to hospital because of COVID-19. So the reason for admission was because they had respiratory symptoms and or exacerbation of their underlying conditions because of COVID. And we see there's 218, about 40% of this chart review were people who were admitted because of COVID. And about 16% additionally required critical care. And over the period of time that we looked at in December and January, there were non-COVID-19 related admissions where the reason for admission was not related to COVID-19, but they had a positive COVID test, and that was about 244 or 44% of the cases. But when we look at this by breaking it down by the variant of concerns that we know are causing infections in hospital, we can see that for people with Delta, it is primarily people being admitted because of COVID-19, and a much higher proportion of those people are requiring critical care. And so that's important for us to know. This issue of people who are admitted to hospital with other diagnoses and test positive really is related to what we are seeing in the last few weeks as Omicron has spread so much in the community. And we can see that about 60% of admissions that were related to Omicron were not because of the infection, but people who were admitted and tested and found to have a positive test. So this is important. And for those that we don't yet have the whole genome sequencing, we see that the pattern, though those are more recent cases for the most part, the pattern is very similar to what we're seeing with Omicron. So that's telling us as Omicron has spread in the communities, we are more likely to pick it up when people are admitted to hospital for other reasons. And those other reasons are what keep them in hospital or require are reasons why they're in for a period of time. There is, of course, still unimportant, about 40% of people who are admissions because of COVID, because of their underlying illness, and a much smaller proportion compared to people who are admitted with Delta infection are people who require critical care. So obviously we want to see how that breaks down by vaccination status as well, and we can see again a different pattern for Delta than for what we see with Omicron. So particularly as we were calling it, and is so apparent when you look at this, that having at least one dose of vaccine, so this includes people who have 1 dose, 2 doses, or 3 doses. So any vaccine is very highly protective when you had Delta circulating in the community. And for people who are unvaccinated, you were much more likely to end up with needing hospital care, and we'll look at age in a minute, and a much higher proportion required critical care. So this is important. As we've moved to Omicron, we see that the incidental cases are much more common in people who are not vaccinated, people who have at least 1 dose of vaccine, and you're much less likely to be admitted because of COVID-related illness or to require critical care. And the pattern that we're seeing in those who we don't yet have the variant of concern is much more similar to Omicron. Again, it just shows us the importance and how we're getting through this phase of this pandemic with so much transmission of Omicron, how important it is that vaccination is preventing people from needing hospital care because of their COVID infection. The other part that we want to look at is this different by age? And the answer for that is, again, yes. So if you are admitted for COVID, you are much likely to be younger in Delta. So Delta is causing more severe infections in younger people, and as we've just seen, in younger people who are more likely to be unvaccinated. Whereas with Omicron, in younger people, it's much more likely to be an admission for something else where you had a positive screening test for COVID-19. And finally, just trying to put this all together and determine if Omicron itself is less virulent than Delta. We do see that seems to be the case with the data that we have that shows that if we match everybody and regardless of age, of vaccination status, of the other comorbidities you may have or other illnesses and sex and health authority, that there's about half as much chance of being hospitalized with Omicron. The odds of being hospitalized with Omicron are much less than with Delta. But importantly, 1.3% risk of hospitalization is still very high when you have thousands of people a day who are being infected. And we see from these data that it's incredibly important that the high levels of vaccination that we have in our communities across the board, across age groups, and across communities has made the difference in ensuring that our hospitals were not overwhelmed in this past few weeks. So what does this tell us? 90% of these new hospital admissions are Omicron, as I mentioned. People with Delta stay in hospital longer, are more likely to have severe illness, and the vast majority of those requiring care in hospital were a result in Delta were a result of actually from COVID. Today we have far more people in hospital than we've ever had. And many of those people, as much as 60 or 70% now, especially younger people, are there for other reasons and they've tested positive. And so what this tells us is this is really important. The level of immunity that we have in our community has protected our healthcare system at this most critical time, even when we've had the numbers of people who needed that hospital care. So while it is under severe strain, it is the credit of so many who have stepped up and got that protection that our hospitals are coping, even though we're stretched. The other measures that have made a difference, and we know that, is intervening early with some of those measures in our community that reduces the risk of transmission, reduces the number of people that we've been in contact with. So that has been an important measure as well, and we're looking forward to when we can start to lift some of those measures. But right now, it still remains important to do those things that work, knowing that 1.3% of 2,000 people a day or 1,500 people a day is still a large number of people who could need hospital care. So with the increase in transmission in our communities, we've also seen an increase in people who have COVID in our long-term care and seniors assisted living facilities, and we've seen that reflected in the numbers of outbreaks that we're seeing. And while there is no question that, again, our seniors and elders in care are being affected, we are seeing a difference very similar to what we saw in hospital, where the severity of illness for most is far less. And this is absolutely because of the very high levels of vaccination and booster doses in residents of long-term care and in staff. In previous surges, we needed to take blanket measures, one size fits all across the province when we had high levels of community transmission to prevent this virus from entering into our long-term care homes. Those protocols had impacts themselves, and we know that. Now, while some measures continue to apply, we are adjusting this outbreak management approach, reflecting very high levels of transmission, but much less severity for most people because of that high level of protection we have through vaccination and through short-term protection through people who've been infected now. So this one-size-fits-all approach is no longer applicable, and we've updated the guidelines around management of long-term care and visitors in long-term care, and those will be posted on the BC CDC website later today. I will remind people we do have some measures in place that were put in place in December as Omicron was starting to increase, and because of all of the transmission that we're seeing in communities. So this includes things like reducing the numbers of visitors. It's important that with the vaccination status of staff and visitors and residents, making sure we got booster doses into everybody, and wearing PPE at all times for healthcare workers, and when visitors are in, making sure that they're wearing PPE, that they only visit the person that they're there to see. But we are also acutely aware of the impact of the extended social isolation that comes with the full closures of long-term care homes. And we've been trying to find that balance of minimizing the risk to residents in long-term care, minimizing the transmission of the virus, as well as finding that balance of having that all-important contact with our loved ones and making sure that we can have those social interactions that are so important. It is important that we continue to have that balance, and doors will be kept open right now. That is the way that we've been trying to manage this, to allow all residents to have up to 2 visitors, one at all times, regardless of whether there's an outbreak, whether there's some COVID in that facility, and the community transmission rates. So this is one essential visitor. About a third of residents of long-term care have an essential designated visitor already. But for every resident of long-term care, they can have a designated visitor. So that can be 2 for some people, but a designated visitor for every resident of their choice. And yes, you can have a backup in case you can't go, but one at a time, making sure that we do have that all-important connection with at least one additional person, and for many people, 2 additional people, even if there are cases of COVID in the facility. What remains unchanged is that these visitors must be fully vaccinated themselves. That's how we manage this risk, and must continue to wear PPE. When it comes to declaring an outbreak, we are using a criteria approach based on judgment and the scope and severity of the outbreak. And there are a number of different factors that medical health officers with our teams of infection control and support for each facility and working with the facility use when an outbreak, when there's transmission within the facility, and whether an outbreak needs to be declared and what measures are in place to try and manage that. We also have updated our guidance around timely communication of outbreaks and cases in long-term care and assisted living homes. So those details will be posted today. Our focus continues to be to protect those who are most vulnerable to severe illness, whether it's in the community, in long-term care, in hospital. And that's why we all need to continue to do the measures that we're doing to protect our healthcare system, to make sure we can get through this wave too, and to keep our communities open and going as much as possible. It's about finding, once again, and keeping our balance. We know that COVID-19, this virus, is going to be with us for some time still. But we are progressing through this surge, which means we can look very soon at starting to gradually ease restrictions in the weeks ahead as we get closer, and we've put limits on some of the restrictions on events and gatherings that will be coming up for review in the middle of February. And we'll look at where we are in our journey through this phase by that time. As we have done previously, it will not be a flick of the switch. It'll be, again, increasing the dimmer switch, a gradual turning of the dial, so that we can do this cautiously and not put people at risk as we're getting closer and closer to the end of this wave. It is a new lunar year, a new month, and a time for cautious optimism. But we still have ways to go on our journey yet. And we all need to continue to do our part as we progress through this pandemic together. Thank you.
Thank you very much, Dr. Henry. And I wanted to start by talking about the continuing and extraordinary efforts of our vaccination campaign across BC. 10,778,839 doses administered as of last night. That's 4,460,130 first doses, 4,166,205 second doses, 2,152,504 third doses, which is, in this recent period, an extraordinary effort. I might add, in addition to that, that we see a very significant number of young people, now over 50% of children 5 to 11, I should say, who have received their first dose of the COVID-19 vaccine, and that number as of last night is 182,958. And an additional 12,300 with second doses and 28,000 with booked second dose appointments. So that process is going on and moving forward really effectively. I think that there's often a discussion about differences in between vaccinated and unvaccinated. But what that represents is 93.1% of people who are have received their first dose immunization of adults who have received their first dose immunization against COVID-19. So when we talk about divisions, it's 16 people vaccinated for every one person unvaccinated. And I think what we see, in fact, and we've seen in our vaccination effort from our teams of medical professionals, of our teams of volunteers, of our teams of communities and municipalities who have supported it, and of the many and of the millions of people, including the more than 4 million people who have and are using their BC vaccine card. Extraordinary amount of consensus in our joint effort and our joint commitment to one another to help us get through this. And we see this every day and in every way across the system. We see it with family members finding different ways to support people in long-term care, and the announcements made by Dr. Henry are gratifying for many people in this group. We see it in how we help one another. We see it in people sometimes dropping off meals when people are in isolation to make their lives better. We see it everywhere. And I think, well, there is always going to be discussion of divergence and conflict. The level of consensus and collective effort here in BC is something of which we should all be very proud, and I certainly am in particular. I want to provide an update today on where we are in terms of acute care, just not in terms of people in hospital with a positive test for COVID-19. Dr. Henry has been talking about that, but overall in the system. As you know, there are 9,229 base beds in our system. Today, 8,776 of those are full. We have 2,353 surge beds across the acute care system. Today, 582 of those are full. So that's a total of people in our acute care system that is 9,358. So that is above the base bed level, well below obviously the base and surge bed level. But what it tells you is that our hospitals are very busy providing exceptional care to a lot of people. In terms of critical care, we have 510 base critical care beds and 218 surge beds. Of the 510 beds, 448 of those are full today. Of the 218 surge beds, 30 of those are full today. So that's a total of 478 people in critical care. I want to give a brief update on the impact of sickness on healthcare workers and the healthcare system. Health authorities obviously continue to closely monitor sickness levels across health services, especially in hospitals, long-term care, and home support. I can report from January 24th to 30th, 17,756 healthcare workers called in sick. That includes 4,033 in Fraser Health, 3,456 in Interior Health, 1,656 in Northern Health, 1,773 in the Provincial Health Services Authority, that includes the BC Emergency Health Services, 2,714 in Vancouver Coastal Health, 3,406 in Island Health, and 718 in Providence Healthcare. This is the number of healthcare workers affected and does not reflect the number of days or shifts they may have called in sick. The illness could be due to COVID-19 or something else. The number of healthcare workers, as you can tell, is relatively unchanged from last week or the week before. So the situation remains very challenging, very difficult, but it is not getting demonstrably better in terms of overall sickness or worse over the last couple of weeks. It is staying remarkably, in fact, similar in terms of the statistics. I want to thank everybody working in healthcare. It goes without saying, I think, but we should say it again and again if we can, who have been working exceptionally hard under enormous pressure to get British Columbians through this pandemic and to provide exceptional services in communities across BC. With respect to rapid tests, BC has now received, as of January 31st, 2020, 10,187,385 rapid tests and deployed 5,927,284 of these tests to key strategic area. This leaves a current inventory of 4,260,101 tests, 2,658,000 of which we received in the last 3 days, so since on the weekend and since. As you know, as we've discussed before, 556,896 of these tests are not packaged suitably for takeaway or personal use, leaving 3,703,205 tests that are suitable for self-administered use. This week, subject to timely delivery from the federal government, we will be working to deliver over 1,291,000 test kits as follows: 351,000 for repackaging and distribution to COVID test sites across BC to replenish their supply, 100,000 to replenish supply at acute care centers for symptomatic healthcare workers and health authority programs, for example, emergency departments. $260,000 to support testing of visitors and symptomatic staff in long-term care and symptomatic staff in assisted living. $130,000 to support rural, remote, and Indigenous communities. $300,000 more tests to support K-12 education. As more tests arrive, we will continue to push to the areas in greatest need and expand across post-secondary, childcare, and other areas, as identified in the plan that was presented on December 21st, 2021. Currently, BC, and this is a change, expects to receive 16,597,515 tests between today, February 1st, and the middle of February. This is an increase from the 15,719,920 that we were expecting as of January 20th, and an increase from the number that we provided last week. This is good news. Clearly, the supply of tests is substantial, but it's also in flux as orders and deliveries get firmed up by the federal government. And finally, I want to provide our weekly surgical renewal update. Health authorities reported in the week of January 2nd to January 8th, which included a statutory holiday, 4,976 surgeries were completed in that week. From January 23rd to January 29th, health authorities postponed 870 non-urgent scheduled surgeries. That's 104 in Fraser Health, 15 in Vancouver Coastal Health, 572 in Interior Health, 171 in Island Health, 8 in the Provincial Health Services Authority. No surgeries were postponed in the Northern Health Authority. And just to put that in context, that's a significant number, and it's impacting a lot of people and a lot of families, although it's significantly less when the suspension of non-urgent scheduled surgeries in the April and May 2020 period in the first phase, the first wave of the pandemic. Cumulatively, from September 5th to 2021 to January 29th, 2022, regional surges of COVID-19 and factors including severe weather patterns have caused 6,762 surgical postponements. As reported, there are over 1,000 people, and there will be today, in hospital with COVID. There's still a very significant number, although less relatively speaking compared to the total number than before in our intensive care units. And we're still losing loved ones to COVID on a daily basis. Well, there's more important progress on other fronts that reflect our hard work to stop the spread. We know this, and this is something we do together in British Columbia, and we've done together very effectively. We know our work is not done. We know this too, that our actions to slow COVID's current surge have a direct impact on our healthcare system's capacity to perform in the many ways we count on it to perform, to do the many things we rely on it to do, and to deliver the remarkable outcomes we've come to expect from it. Patients will get their calls to rebook their surgeries. Healthcare workers and teams will get the respite they need from COVID's current push. And all of us will share in the relief those achievements bring when we continue to do the work that so many are counting on us to continue to do. Keep wearing our mask, keep using our physical distance, keep using our COVID sense, keep adhering to health orders, keep embracing health guidelines, keep getting vaccinated in these exceptional numbers, and keep protecting our children with their vaccinations and getting our third shots and boosters when it's our turn. That's our work, and when we do it, we make all the difference in the moments that matter. And with that, we're happy to take your questions.
As a reminder to reporters on the phone, please press *1 to enter the queue. You will be limited to one question and one follow-up.
And I'm just going to give a quick update on one other issue that I missed my notes on. We talked last week, and the National Advisory Committee on Immunization came out with recommendations around booster doses for 12 to 17-year-olds. And they did confirm a 6-month interval was the interval to be used. They also confirmed, and this is something that we'll be making sure people have access to later this week, that people who, similar to adults who have in the 12 to 17-year age group who have clinically extremely vulnerable, have immune compromising conditions and a few other conditions, should get a third dose as part of your primary series, and then a fourth booster dose 6 months after that. So that will affect some people who are immune compromised in that age group, and you'll be receiving your invitations for that. For other people in the 12 to 17-year age group, NACI has recommended that a booster dose be provided to people who are at high risk, and we for a number of conditions, and we have those outlined at 6 months of age. So that's people with diabetes, people with a number of other conditions that increase the risk of having more severe illness. And for others, it is, in NACI's opinion, more of an optional risk-benefit analysis that you do yourself. So how we will be doing it here in BC, after discussion with our BC Immunization Committee and our immunization team, we will be sending invites to all 12 to 17-year-olds with information on the benefits and risks of boosters at your 6-month interval. And you will have the ability to make that decision and book yourself. And we do, of course, continue to strongly recommend that anybody who has an underlying condition that puts them at risk does get their booster dose. We have seen, and we see it in the hospitalization data, that it's important for protection not only against infection, even from Omicron, but also really important for longer-term protection against severe illness.